I'm Kristen Ciombor. I'm an associate professor of medicine at the Vanderbilt Ingram Cancer Center, and today I'm going to talk about non-targeted treatment approaches for relapsed and refractory metastatic colorectal cancer. So I think in the last few years, we've been really excited to see all of these molecularly targeted agents, but to be honest, those still affect a minority of patients. So this is something that's critically important for the majority of our patients that we see with metastatic colorectal cancer, whether or not they have targets that we can basically hit. So starting about 10 years ago, we developed several drugs in the field looking at patients who had refractory disease. First one, of course, is regorafenib. And regorafenib is thought of as typically an anti-VEGF therapy, but really it hits multiple targets. And so that's how it's a little bit different from, say, bevacizumab. So regorafenib is a TKI that's oral, and it not only hits the VEGF receptor and Tie2, but also PDGFR, FGFR, KIT, RET, and other targets that can be upregulated in colorectal cancer, particularly with prior exposure to things like bevacizumab. It has a relatively long half-life, and that's important for the dosing strategy. So the correct study was a global phase 3 that ultimately led to FDA approval of this drug in colorectal cancer. And there was a 2-to-1 randomization. Now, the dose at that time was 160 milligrams, which is the FDA approved dose. We'll talk a little bit about why, how we can modify that potentially. And then the other arm was placebo plus best supportive care. The primary endpoint here was overall survival. So who are the patients that enrolled on the study? I think this is really important in the refractory setting, and I'll point that out with each trial. But these patients had all had prior bevacizumab. So they were not naive to anti-VEGF therapy, but almost half of patients enrolled on this study had 4 prior lines of therapy. So very refractory patient population, had primarily had all lines of therapy available to them prior to enrollment on the study, which also is implicated because it's a placebo-controlled study. Most of these patients had metastatic disease for a long time, which kind of goes along with that as well. So what we saw with the correct study was that regorafenib did have a statistically significant overall survival advantage over placebo, and this was about a month and a half, so 6.4 versus 5 months, which was important, though incremental, in the treatment of these patients. Now, I alluded to the fact that the original dose and the FDA-approved dose is 160 milligrams, and that's 3 weeks on, 1 week off. However, when we started utilizing this drug in the clinic, of course, we found that it was hard to tolerate, and for the majority of patients. So that actually led to us doing this study called REDOSE, which was a randomized phase 2 study to look at different dosing strategies. And there were 2 different randomizations here. One of them was a dose escalation of regorafenib, so starting at 80 milligrams and then every week escalating to 160 milligrams if tolerated. Otherwise, you could stay at the maximally tolerated dose. And then the other randomization was doing a preemptive versus reactive randomization of clobetasol. So basically, since hand-foot syndrome is another classic toxicity with regorafenib, trying to see if using these high-potency topical steroids prior to the onset of hand-foot versus when it develops, if that was helpful. So what we saw from REDOSE, and the primary endpoint here was interesting, it was actually the percentage of patients starting cycle 3. So essentially being able to continue on the drug in a tolerable manner. And the study did meet the primary endpoint. So 43% of patients in Arm A, which was the dose escalation arm, versus 25% of patients starting at full dose, actually made it to cycle 3, staying on the drug. So there was not an overall survival advantage, actually wasn't really powered for that, but there did look to be a trend in median overall survival improving in the patients who started out at a lower dose.
I'm just kind of curious. I imagine you use a fair amount of regorafenib, but globally, how often do you see responses? And how often do you see people that you feel are actually benefit? Because it's kind of hard
Yeah.
to evaluate if a patient doesn't respond. So, how often do you see objective response, and how often do you see patients that you just think are benefiting, although you maybe don't see a response?
Yes. So very few objective responses. So both regorafenib, TAS 102 rarely see that 30% decrease. I've seen it maybe once. Um, so we don't really expect that. But really at that with that refractory patient population, if patients can have stable disease for a period of time, then that can be helpful too, maybe as a bridging treatment to get to a clinical trial or something else. So I have seen patients over time who I think have benefited. So the other question is, of course, do these patients just have indolent disease and then they're not progressing, but they're not really benefiting? They would have the same time to progression even if they were not on regorafenib. And that's probably true for a subset of patients, but I definitely see patients who their disease was progressing quickly prior to going on regorafenib, and then they have stable disease while on drug. And sometimes we see, and this is just anecdotally, but sometimes I see cavitary lesions, particularly in the lungs, that is clearly a drug effect because they didn't have those initially. And so that's just something that I've seen in my experience.
Yeah, that brings back old memories. We used to talk about that in CME programs when we need to have anything else to talk about. I remember seeing, images of that
Yeah,
cavitation things.
yeah,
Oh, maybe it does respond, but
yeah, yeah.
interesting. All right. And the other question I have is, I assume use the redose approach,
I
and
do.
if so, what fraction of patients, really have no problem? They just sort of cruise through it.
Very few. I could probably count on one hand the number of patients who can get up to full dose using the dose escalation. But I have had a few, and they really, I mean, I quiz them on every toxicity, and they really seem to tolerate it well. I would say it's much more common to get to the 120 dose. And then there are some patients who really can't go beyond the 80. And you can still see disease, stability on those doses too. So I do think that can be still helpful.
Well, I was thinking more in terms of when you look at the overall experience that these patients have on the drug, what fraction of them, when you use the redose strategy, it's not so much that they get escalated, but what fraction, when you look back at their course, really didn't have significant side effects?
Oh, in general. Um,
Yeah.
I think it's dose dependent, clearly, but there is a subset of patients who manage it fairly well, especially if they're counseled appropriately. And I do try to do the preemptive, steroids too, so that they know all of the going in, they know all of the kind of tricks to have this be tolerable.
Can you understand how somebody from the outside might question why it's being used?
Oh yes,
You're about to
yeah.
get into task 102 plus or minus Bev. Do you have that same feeling with that? Because I sort of don't. I feel like something, particularly with Bev, I feel like there's more there, but I don't know. What do you think?
Completely. I completely agree. So we actually started using TASBEV prior to the phase 3 data, just based on the early phase data, which really looked promising. And I can tell you from my clinical experience, there's a clear difference. So that has become my new standard in the refractory patient population. So I do use it prior to regorafenib, both from
And you're
toxicity
about to
standpoint as well as efficacy.
and you're about to go through that data, but I'll just put
Mhm.
the same before you go through the data. I'll put the same question out I just put to you for regorafenib. How often, let's say with Bev, globally in your practice, are you seeing people respond, and how often do you
Mhm.
see people who have to have dose holds, et cetera, because of
Mhm.
quality life toxicity?
Yeah. So again, we don't see a ton of objective responses even with TASBEV, though it is a little bit higher, and I'll show you that data from Sunlight at least. But I do find that toxicity is much more reasonable, and I don't often have to dose reduce. Occasionally, I do for cytopenias from the TAS 102. that being said, I don't use the same dosing schedule that Sunlight did. I actually do every other week TAS dosing, which I think makes a difference as well.
All right, let's talk about the data.
Okay. So TAS 102, the mechanism of action here is a little bit different, where it really is more like a cytotoxic agent. So it's a combination of trifluridine and tipiracil. Trifluridine is actually the nucleoside analog or the cytotoxic drug, and then tipiracil is the thymidine phosphorylase inhibitor that kind of keeps the drug active. So Recourse was the global phase 3 study that did get this drug approved in this setting. So again, fairly similar patient populations. Patients were randomized again 2-to-1, TAS 102 plus best supportive care versus placebo plus best supportive care with a primary endpoint of overall survival. These patients had all prior standard lines of therapy at that time as well. So overall survival, again, the overall difference between the active drug and placebo, much like the regorafenib trial, was pretty similar. It's about a month and a half, and that was pretty consistent. PFS was also similarly improved. Then subsequently, a few years later, there was the early phase data coming out about TAS 102 plus or minus bevacizumab. And though these were smaller studies and earlier phase data, not large phase 3 data, we did see an improvement that looked almost a little bit hard to believe, but kind of made us intrigued to follow the data and see where that would go. So the addition of bevacizumab, and again, these were patients who had prior bevacizumab for the most part. So adding that to TAS 102, and probably because of the mechanism of action, more like a cytotoxic plus Bev, like we do in earlier lines of therapy, actually did look better, both in terms of PFS as well as overall survival. So it's on the basis of that data that actually our clinical practice changed, and we started using TAS Bev even before the Sunlight data was presented earlier this year by Dr. Tabernero. So at ASCO GI, we heard the official data of the phase 3. And this was a global study like the others. Some patients received TAS 102 plus or minus Bev, and then overall survival being the primary endpoint here. So I think it's always important to look at which patients were actually being enrolled. So, and in these refractory patient populations, it's really important to look at exactly what prior lines of therapy they had. And interestingly, only about 3/4 had prior anti-VEGF, most of those being bevacizumab. So that's a little different from some of the other studies like the regorafenib studies. So I think that's a little bit of an important difference, but this is reflective of the global differences in practice patterns. So overall survival as the primary endpoint did show about a 3-month survival advantage. And you'll notice that the overall survival in general in these groups were a little bit higher than we saw in either Correct or Recourse. So this was a clear separation of curves really from very early on in the treatment course. Again, also PFS was statistically significantly better with more than a doubling. And here are the response data. So as I mentioned earlier, we don't really see a lot of disease responses, objective responses, but at least by RECIST criteria with either regorafenib or TAS 102. And so we did see a hint of an improvement in that with the addition of bevacizumab to TAS 102. So I thought this was intriguing, and this was statistically significantly different. And then we also saw a better disease control rate. So I think clinically in my practice, I see this all the time where patients really, there is a difference between TAS-BEV and TAS alone. So I really, for the patients who might have a relative contraindication to bevacizumab, I really work hard to understand how relative that contraindication is, because I do think it's an important addition.
So I just had a crazy thought that you're going to say it was tried and it was too toxic, but has TAS 102 been combined with regorafenib?
Not to my knowledge, though there have been some discussions about whether the addition of, say, fruquintinib to TAS 102. So that's kind of a natural next step or combination, I think, that makes a lot of sense to explore given the oral nature of both of those agents.
Well, it also ties into why you see, a hazard rate of 0.61 here with, not everybody had BEV, but a lot of them did have BEV. And,
Hmm.
we commonly give BEV second line after people progress. There's
Yeah,
data supporting that with switching
yeah.
the chemo. What's your explanation? It doesn't seem to fit the conventional model of resistance to continue giving the same strategy and you continue to see benefit. What do you think's going on?
I know. And the other interesting thing is that it seems like the benefit is actually more in the later lines of therapy. It doesn't get more and more incremental. Whereas, you see a little bit, month and a half PFS difference or 2 months at most for the addition of anti-VEGF agents like BEV and others in the earlier lines of therapy. But as you get later, like with sunlight, you actually saw really more improvement. So I don't know why that is. I sometimes wonder if maybe it's just because with prior lines of therapy, one of the mechanisms of resistance is the increase in these angiogenic agent, factors. And so maybe that's why it still has activity later on. But I think it's a really intriguing point and has a lot of implication for how we treat this disease.
I'm starting to get all these flashbacks to things that we used to talk about when we had not very much to talk about. And, in terms of that, a really basic question that goes back a long time is like, why do they even work to start with? Why
Yeah.
do you, seems like it potentiates, is it something to do with the vascular permeability or what? I've been talking about for 20 years. What are the current thoughts about it?
Yeah, it goes back to Judah Folkman, doesn't it? So
Right,
we've been talking about
exactly.
this for a long time. Yeah, I think there are a lot of still unknowns, and I don't think that this is an area that's being explored quite as much as it was in the past. We've sort of moved on to all the molecularly targeted agents, but I think this is still an area ripe for investigation for sure. And not only in colorectal cancer, but in kidney cancer and other areas where that anti-VEGF experience is really important.
And of course, with kidney cancer too, you have the synergy with IOs, which still don't understand that either.
Yes, yes, and HCC, and yeah,
Right,
a lot of really
exactly.
interesting room to explore.
All right, please continue.
So, with the sunlight trial, we really didn't see any new safety signals. I think we're all very familiar with the adverse events and toxicities from bevacizumab. So, this didn't seem to be additional additive safety signals that we were surprised by. But it is important to consider at every point when patients are candidates for this combination because they do have such different toxicities.
What's the current thinking in terms of whether there's a correlation between the neutropenia that you see
Hmm.
and treatment benefit? That at one point there were some data to
Yeah.
suggest that. Do you sort of look for neutropenia as sort of a good sign, so to speak?
I did initially because that was a really interesting hypothesis. Um, to tell you the truth, I actually use different dosing than sunlight does. So I don't use the 2 weeks in a row dosing. I use the every other week, and I don't see a clear correlation between cytopenias and response. But I also don't. If patients need a dose reduction of TAS-102 based on cytopenias, especially neutropenia, I don't necessarily worry as much because I often see, clinical benefit even at the slightly lower doses. But because I have the
Well,
dosing schedule a little bit different, I don't see as much neutropenia, to be honest.
it kind of reminds me also because I don't hear much about febrile neutropenia, and sort of
Hmm.
reminds me of CDK inhibitors in breast cancer that you see
Hmm.
neutropenia, but people don't get so bent out of shape. I'm
Yeah.
curious. Another thing I've kind of wondered about over the years is when you see neutropenia here, do you see more of it in African American patients?
For my practice, I probably can't say. That would be an interesting thing to look at, of course. But yes, I agree with your first point that that we don't tend to worry about it too. We kind of treat through, as opposed to when patients are neutropenic and getting IV cytotoxics, then we say, hold up, we have to delay, and we, we have to do all these things. But we don't see that it clinically is that important in this treatment regimen.
All right, please continue.
So another avenue or potential treatment regimen or treatment paradigm in refractory colorectal cancer which has gotten a lot of thought lately, is anti-EGFR rechallenge. So the idea here is, in the patients who are RAS and RAF wild type who are treated with anti-EGFR antibodies at some point in their disease course, that over time, one of the mechanisms of resistance is the development of different clones, so subclones of their disease, and one of those is KRAS or NRAS mutations. And so now that we have liquid biopsies in our practice, we can actually see this occur at times. So if you see that a patient is losing their response to cetuximab or panitumumab, you might actually send a liquid biopsy if you can, and sometimes you'll see those mutations emerge. And essentially that's selective pressure from the EGFR inhibition. And so when you remove that selective pressure, what we've seen is that those clones can decay and sometimes go away. So they're not the persistent RAS mutations that you see from diagnosis. These are really just the subclones, and in a smaller quantity. Usually you see the allele frequency is low. So if you treat patients with additional lines of therapy, other non-anti-EGFR containing lines of therapy, and then come back, you may actually get a second response or be able to recycle that treatment option. So this is a really interesting idea to me, and I definitely use it in my practice as well, though I do think that there are still some caveats to it, which I'll try to cover. There have been now a few studies, smaller studies, looking at this idea. Cricket was one of them, published back in 2019. So this was a small Italian study that looked at patients who got cetuximab in the first line with an irinotecan-based cytotoxic regimen. And so the Europeans, of course, used first-line anti-EGFR much more than we do here in the US, though that's changing, of course, with the paradigm data. But these patients received first-line cetuximab, then went to second-line oxaliplatin-based, no anti-EGFR, and then went on to third-line cetuximab irinotecan. So again, tried to re-challenge or recycle that. And interestingly, response rate was 21% with a disease control rate of 54%. So more than you might think. This is a non-randomized study, but more than you might think with something that patients have already progressed on. And in fact, when they saw the patients who had confirmed partial responses, they did not find any RAS mutations. And so when they looked at PFS and overall survival curves on the basis of whether the ctDNA actually had RAS wild type, so no mutations in RAS versus RAS mutations, and they found that actually PFS and overall survival were in some cases markedly better in the patients who had RAS wild type disease when they were rechallenged. And another study, which is probably the biggest study, and this was presented at ASCO a few years ago, was the Kronos study. So this was a similar theme where patients had anti-EGFR initially plus chemo, and then got non-anti-EGFR intervening therapy. But the difference here was that they actually had liquid biopsy tested at that time, and they had a kind of a proprietary assay where they looked at a variety of gene mutations, so KRAS, NRAS, BRAF, and then the EGFR ectodomain mutations, because we see that also in response to prior anti-EGFR therapy. And so patients in Kronos, the nice thing here was that you could actually pick prospectively who you would not expect to respond to anti-EGFR rechallenge. So the patients who had mutations in any of these genes were essentially excluded from the study. So you had a higher chance to, these were patients who you clinically thought would be eligible, but, on the basis of liquid biopsy, probably would not be helped by this. And once they removed those patients and then treated the rest of the patients who were RAS wild type, response rate was 30%, which is pretty decent in this refractory patient population. And about 2/3 of patients wound up having disease control for at least 4 months. And here's the waterfall plot that you can see in terms of how patients did overall. So, and the other interesting thing is we typically think of in terms of the time to subclone decay. So we tend to think there was another study, I think out of MD Anderson, that looked at the half-life of these clones and found that it was on average about 4 months. So if you waited, if you could treat patients with something else for 4 months and then go back to the anti-EGFR antibody, then you might have a better chance of those RAS mutations going away in the interim. But what they actually found with Kronos was that the presence of those mutations and response was actually independent of time since the last anti-EGFR treatment. So you could see it across the board. I mean, they didn't really look before 3 months, but really you could see it at any point. So maybe we have some more to learn about that as well. And finally, the CAVE study was another interesting study published a couple years ago. This was a single arm phase 2 as well, looking at cetuximab rechallenge plus avelumab in patients with RAS wild type colorectal cancer. So in their overall survival and PFS and the intent to treat population, they saw an overall survival about a year and then PFS of about 3.5 months. So again, more than you might expect for a patient who had already progressed on prior lines of therapy. But what I thought was interesting about CAVE was when they looked at, again, the presence of mutations in RAS or BRAF and correlated that with survival, either PFS or overall survival, they saw that the patients who were wild type at the time of treatment at baseline did have markedly better survival. So I think we're getting some data that this is an intriguing treatment paradigm and certainly could warrant more investigation, but I do think that it does make sense.
So getting back to things we used to talk about a lot more, but I'm just kind of curious because of your location. What do you see in your practice nowadays in terms of infusion reactions?
Yeah. So we actually don't give cetuximab in our GI group. Because we can give panitumumab, we have another option. So the only time we actually give cetuximab is if it's on trial and it's not, panitumumab's not allowed. Now, of course, our head and neck group still give a lot of cetuximab. So from my knowledge, I think the infusion reaction rate is still pretty high, but it just depends. We have such a large catchment area, so we have patients from a lot of different areas, and not necessarily only the infusion belt, so to speak, infusion reaction belt, but it's something I'm definitely grateful to have an alternative to cetuximab, at least for colon cancer.
Yeah, I always thought that whole story was so fascinating. Anything new in terms of what actually is going on and like what the difference is between panitumumab and cetuximab that you see such a difference in the infusion reactions?
Yeah, I mean, I think it's IgE mediated and just the epitopes on cetuximab versus panitumumab, but I haven't heard anything lately in terms of new knowledge.
And again, I remember in the past they talked about ticks or some,
Yeah,
infections or something. Is that still
yeah.
the thinking?
I think so, and you hear a lot more about alpha-gal syndrome, and I have several patients actually now not getting panitumumab or cetuximab, but we're hearing an increased prevalence in that and those kinds of tick mediated anaphylaxis even, and with exposure to meat after those tick bites. So I wonder if there is any correlation between those patients as well, if they were to get panitumumab or cetuximab.
Interesting. Please continue.
And the most recent study we've had in the colorectal space, in the refractory colorectal space, is FRESCO-2, which was presented at ESMO last year, 2022. And this was the global study of fruquintinib, which is another anti-VEGF agent. So this is a little bit little bit different, but also an oral TKI where patients receive it 3 weeks on, 1 week off. And when we looked at the number of patients and the types of patients that were enrolled, this was very much in contrast to the original Fresco study, which is what got regulatory approval in China for fruquintinib. But those patients in that study, patients really hadn't seen prior anti-VEGF as nearly as much as we do at the current time here in the US. But this is a global study, Fresco 2, but really wanted to look at, okay, in the patients who have truly gotten all lines of therapy or very close to it, how does this agent hold up? So what I think it's important to look at here, and in this figure, which was presented at ESMO, the median number of prior treatment lines in metastatic disease was presented as 5. In the subsequent publication, it was actually 4 because the 5 was including adjuvant lines. So that was a little bit of an update. But here, almost every patient had prior VEGF inhibitor. So that was a little different from, say, Sunlight. And not only that, but in contrast to the other trials, now that we have the availability of TAS-102 and regorafenib, about half the patients had prior TAS-102, about 10% had prior rego, and then about 40% had both. So these were very truly patients who didn't have any treatment lines left. Primary endpoint here, overall survival, and we saw about a 2.5-month improvement with the curve separating pretty early on, and with a median follow-up at that time of just under a year. In terms of the subgroup analysis, to look at which subgroups may have benefited a little bit more, it did look like it was favored for fruquintinib across the board. Might be, certainly there were very few patients who had not received prior anti-VEGF, but it did look like those patients benefited more, which you might expect. And then in terms of prior refractory lines of therapy, so TAS-102, regorafenib, really patients could benefit no matter what they had previously. It wasn't like if they had all lines of therapy, they were less likely, or, having regorafenib, they were less likely to benefit. PFS was a secondary endpoint, and again, about 2 months PFS difference with fruquintinib. And again, the anti-tumor activity, this is another agent where we don't see much objective RECIST response, and that's also similar with, when we looked at bevacizumab too. So you don't see a lot of tumor shrinkage, but the disease control rate in this highly refractory patient population was 55% versus 16% in the placebo arm. The adverse events and toxicities were pretty expected, I would say, with an anti-VEGF. I do think, I'm sure you'll ask me this, Neil, but I do think this is a better tolerated drug than regorafenib in my clinical experience. So you don't see the same degree of toxicities in terms of hand, foot, and other things like that, and fatigue. And we did participate on Fresco too, so I had firsthand experience with this drug. Of course, it's the PDUFA date for the FDA is the end of November. So if fruquintinib is deemed sufficiently active by the FDA, we may have a new drug for colorectal cancer here in the near future.
So, of course, I'm going to ask you, if and when it does get approved, how or are you going to use it, and what's going to happen to regorafenib?
Yep. That's a great question. So I'll give you my thoughts. I don't know if this will be reflective, but based on the data and in what populations these drugs were tested in, I do think that at the current time, fruquintinib comes after at least TAS-102 Bev. So I would use that as my first line of therapy after the general cytotoxics, and then and targeted agents, for instance. But after TAS-102, it's good to have an additional line of therapy. So if I do think patients can handle toxicity of regorafenib, I'll probably still use that drug. But I do think that that fruquintinib is a bit better tolerated. So I think that will be the big question of how practitioners utilize this drug. I think the next important question is, are there going to be combinations where this is helpful? We talked a little bit about fruquintinib plus TAS or, other agents as well. So I think that's the next question to answer. So it'll probably stay in the refractory setting initially until we have other data, if we get other data that looks good in the future. But it's always nice to have another line of therapy, and an oral line of therapy where patients, can have that and not be tied to their 5FU pump or whatnot.
But, it kind of seems like it'd be great that if you feel like, there's a palpable difference in tolerability, given the borderline efficacy, it seems like it'd be attractive to try to go with fruquintinib. I guess we'll see how people think it through, or maybe if we get more data. But I guess there's no redose-like thing with fruquintinib that you have to start low and all that.
No, and I actually found, at least on Fresco-2, in my experience, we didn't have to dose reduce it very much at all. So whereas with regorafenib, we knew immediately this dose is hard to tolerate. So and again, we didn't participate in that study, but so I don't know how it was tolerated in the clinical trial, but the Fresco-2 was a lot more tolerable.
So I'm just going to ask you one more thing, because I'm just curious what your thought is in terms of new approaches in the management of metastatic colorectal cancer. Anything in particular that you're excited about? Of course, cellular therapy is something you hear a lot of interest in general in oncology. But from your point of view, what are the most exciting areas of new trials?
Yeah, good question. So I think, we're still struggling to get immunotherapy to work in the microsatellite stable population. We're seeing such amazing responses earlier and earlier lines of therapy for MSI high disease. So we just have to figure out how to get that to work. So of course the newest data there is the BOT-BAL study, and there's the ongoing study right now that's looking at that. Of course, that's really interesting because the currently enrolling study is not allowing patients with liver metastases. So when we've seen over and over in multiple studies like Rigo-Nivo and others that, the patients with liver mets don't respond as well. So there's clearly a signal there that we need to explore more. There are some safety concerns, I think, and I think we're still scratching the surface, but that's probably an area where we really need to improve upon to be able to have hopefully durable responses like we see in other cancer types and even in MSI high disease.
You were referring, though, to a regimen. I'm not sure what it was, though.
Oh, the botensilimab balstilimab study. So
Oh,
the
right.
BOT-BAL for
Okay.
short. It's a
Right. Oh,
mouthful for
got it.
sure. Yeah. PD-1 and anti-CTLA-4, but just a little bit different.
Right. A different version of Ipi-Nivo. Yeah.
Hmm.
Interesting.